Good morning, everybody. I'm Dr. Dennis Goodman. Welcome to our Heart Health Lecture Series, presented by the Center for Prevention of Cardiovascular Disease. Next slide. I am a clinical professor in the Department of Medicine and Director of Integrated Medicine, and the founder of our lecture series. I'm very proud of this lecture series, and it's very much part of our prevention team and our prevention program. We have a very loyal audience, which is growing rapidly, and I'll tell you about some of the lectures we've had, and we're very excited to have a wonderful speaker tonight. Next slide. So this whole series is based on the idea that I have and everybody has, that prevention is so much better than trying to cure something. 80% of heart attacks and strokes are preventable, and many other chronic conditions. And the ways that we focus on prevention are nutrition, and that includes supplementation at times, supplements, exercise and flexibility, sleep, the importance of sleep, stress management, and socialization and connection, which is so important for being healthy and preventing heart disease and cardiovascular disease and many other chronic illnesses. Next slide. So we've had a Heart Health lecture series based on many of these topics. Many of you are regulars. We've been doing this since 2015. We've held over 60 lectures on topics related to heart health and conditions that increase cardiovascular risk. And you can see many of those topics. We've done cholesterol in the past, but we like to update things every few years, and we're very lucky to be able to get an update tonight. Next slide. So we have a video library, and most of the lectures have been recorded, and you're able to go and hear them if you miss it or if you want to hear one again. And we've had over 35 on-demand videos, and we've had about 80 to 90,000 hits on our videos. So we're very, very excited about that. And we'll tell you how to get to those videos in a minute. So registration's opening soon. And the next topic is going to be an update on aspirin and blood thinners by Dr. Jeffrey Berger, who is head of our prevention program. And that's on Tuesday, March 12th. Very shortly, we'll be opening up for registration, and I'll give you the website address to register. And that will be an outstanding program. So if you want to register for that and any of our programs, the website address is nyulangone.org/hearthealthlectures. Next slide. So if you keep in touch with us, I just gave you the website. You can also email us at hearthealth@nyulangone.org. We're also on Instagram and Twitter at NYUCVDprevent. This is just to tell you that if you have a question during the talk, you can put it in the Q&A, and I'll be fielding the questions, and I'll ask as many as possible. We've already had several questions that have been sent to us, and we're going to tackle those as well. Next slide. This month is February, and it's Heart Month, and we have to remember that it's so important to think about cardiovascular disease, both in men and in women. But we do everything we can to educate the public about how important it is to know about your heart health and to do everything you can to stay healthy. Next slide. So tonight we have an unbelievable, outstanding speaker who's going to talk about cholesterol. I called it the good, the bad, and lipoprotein A, which is a very hot topic, and Dr. Underberg is going to speak about it. Our speaker tonight is our NYU, our very own Langone expert, Dr. James Underberg. He's got very many titles. He's a clinical lipidologist. He's a clinical assistant professor of medicine at NYU School of Medicine and the NYU Center for Prevention of Cardiovascular Disease. His undergraduate and graduate degrees are from Yale University, and his medical degree is from the University of Pennsylvania. His internship and residency was at NYU and Bellevue Hospitals in New York City. Dr. Underberg is the director of the Bellevue Hospital Lipid Clinic. He holds joint appointments in the Division of General Internal Medicine and Endocrinology at NYU. Dr. Underberg is master of the National Lipid Association. He's the past president of the National Lipid Association. He's the past president of the American Board of Clinical Lipidology and current president of the Foundation of the National Lipid Association. He serves on the editorial board of the Journal of Clinical Lipidology and is a section editor of Current Atherosclerosis Report. Dr. Underberg's clinical interests focus on the clinical management of patients with lipids and lipoprotein disorders and cardiovascular disease prevention. He maintains an active clinical research program in these areas and has authored numerous articles and book chapters in the field of clinical lipidology. He sees patients at Bellevue and in a private practice setting. Dr. Underberg, it's a pleasure to have you. I consider you a friend and a world expert in this area. We all turn to you with problems and difficult cases. I don't think you see any simple cases anymore, simple problems. They're all complicated, and you're very much a world expert on familial hyperlipidemia and how to manage lipid problems and how to deal with Lp(a). So welcome to our lecture series, and thank you so much for joining us. I'll hand it over to you.
Well, thank you very much, Dr. Goodman. It's great to be able to talk to everyone today. I appreciate the kind introduction. I always remind everyone the definition of an expert is someone who's more than 50 miles from home and shows slides. So I'm unfortunately still here, but I do have slides, so I guess that counts a little bit. This is me and my home, which is NYU in Bellevue. I did my training at Bellevue and still have very fond memories of my time there, which is why I spend one morning a week running our lipid clinic there at Bellevue. You can also find me on Twitter at LipidDoc. My tweets are limited to cholesterol and heart disease prevention, but I'm always amazed at how many people are interested in this area. So certainly feel free to follow us both at NYU CVD Prevent and at LipidDoc. These are my disclosures. I do some consulting in the development of new pharmacologic agents in the field of lipidology and a lot of medical education to other physicians. I wanted to start with this interesting kind of piece. It appeared online in 2017 from a famous cardiologist who did a lot of online blogging named Milton Packer. It was right after a clinical trial had been published that didn't show benefit that was considered robust enough to allow a new drug to come to market. And he wrote that lipid research died last week. He goes on to say, I've never been interested in lipids, but some of my good friends are totally devoted to lipid research. That would include me, at least on the lipid research side. Billions of dollars have been spent to make everyone's lipid profile look good, but I fear that we may now have reached the point of diminishing returns. My friends who are experts in lipids should not feel terribly sad. And my response to that at the time was actually, I don't find that interesting at all. And I'm going to show you throughout the course of this talk today that we've really reached a very exciting time in the management of lipids disorders. And I actually feel sad for some of my colleagues in other fields because I do have a lot of amazing options that I can offer my patients to help them manage their cholesterol. And it's exploding at a rapid rate. And I wish some of the other fields that we care for were experiencing the same explosion in new technology. So here's my outline. I'm going to try and get through this relatively quickly so we have time for Q&A. But I always like to start out with a little bit about history and I have an interest in art history, so I try to combine the two. Some fun facts worth knowing about cholesterol, the role of cholesterol in causing heart disease. In case anyone ever challenges you on that, you'll have some great information to have a conversation. A little bit about cholesterol-lowering medicines. We could spend hours discussing this, and I do when I educate other physicians, but just to give you a framework of how to think about it. And then I want to spend some time talking about, I think, an under-recognized risk factor for heart disease called lipoprotein A. And I think everyone should know about this. And then a bit about the future. I love this from the Chicago World's Fair in 1933, a century of progress. And I think that's what I feel we've come to now. And so I start with the Mona Lisa painting. And I hope that this doesn't spoil your ability to view some of these in the future, but but we know that Leonardo painted this painting over a period of 3 years, from 1503 to 1506. And the name of the woman who sat for the painting is listed there. She was born in Florence in 1479, married at an early age to a older gentleman, a Marchese, and at age 24 actually sat for the painting. And unfortunately, she died several years later at a young age 37, for causes unknown. But we do know what she didn't die from. She didn't have a lingering illness, which was often from infectious disease at the time. She died suddenly in the middle of the night, went to bed healthy, and woke up the next morning and had passed away. Well, didn't wake up the next morning and had passed away. She wasn't killed in a traumatic event. She wasn't knocked over in a donkey cart accident or fell from the top of a tower. It was sudden death in the middle of the night. And so what do we know about her? Well, if you focus in on the painting itself, there are a couple of very interesting findings on this painting. There's an area in the inner part of the nasal fold of her left eye that is a prominent finding. And you can see it a little closer here. It almost looks like yellow discolorations in a patient who has inherited high cholesterol, very similar to what we see in the painting of the Mona Lisa. And if we go in and look at her hands, there are some curious nodular densities on the surface of her hands and fingers that also resemble nodular densities that we see in patients who have extremely high or inherited high cholesterol, familial hypercholesterolemia. And in fact, the Mona Lisa may indeed represent a woman who died sudden death in the setting of inherited high cholesterol, something called familial hypercholesterolemia. Here's a portrait of an older woman painted by Franz Hals in 1633. And again, if we look at her hands, we find these nodular densities that may represent arthritis, but also may represent some of the findings that we see in patients with very high cholesterol. And finding, if we go back much earlier in times, I don't know if any of you have seen this great statue, the Charioteer of Delphi. It exists not only overseas, but a copy of it sits on the steps of the Museum of the Philadelphia Museum of Art. And if you look down at the heels in the Achilles tendon of this statue, there are these protuberant findings that resemble something called Achilles xanthoma that we also see in patients with inherited high cholesterol. And we tend to think of cholesterol as a abnormality that exists because of our lifestyle in the 20th and 21st century. But we can find evidence of early accumulation of high cholesterol and early atherosclerosis going back to some of the studies that have been done on mummies that have been found from early Egyptian times. So cholesterol remains important today. The American Heart Association lists what it considers life's essential eight things that you really need to focus on to help prevent heart disease. And lipids I have pointed out on the bottom here in the purple arrow. And over here on the right also, control cholesterol, high levels of bad cholesterol. I hate using that term bad cholesterol. There's no bad or good cholesterol. There's just cholesterol. Some of it maybe hangs out with the wrong type of folk, but in general, cholesterol is cholesterol, and we describe it as HDL or LDL based on how it's trafficked in the body, and I'll explain that in a little bit. But maintaining optimal levels of cholesterol is a very important component of a heart-healthy lifestyle. And I never like to discuss cholesterol without looking at it within the context of these other risk factors: weight, blood sugar, blood pressure, healthy sleep, smoking or not smoking ideally, activity, and healthy eating. And all of these interact to create a milieu that promotes a heart-healthy lifestyle. So some fun facts about cholesterol. Adipose fat tissue stores the majority of what we call triglycerides in the body, and about 25% of cholesterol, 50% in those who are obese. And these fat cells produce limited cholesterol and rely on certain types of products to deliver cholesterol to the body. And we've heard about different types of cholesterol containing particles. LDL people often think of as the good cholesterol. I mean, the bad cholesterol, HDL is the good cholesterol. But the primary mechanism or role of LDL and HDL is actually to deliver cholesterol to organs in the body that don't make enough on their own. And most of that delivery is actually HDL cholesterol, not LDL cholesterol. Endocrine glands, cholesterol is required to make certain end-stage products, such as estrogen, cortisol, progesterone, testosterone, all comes from estrogen. And most of these make enough on their own, but if they require extra cholesterol, again, it's delivered by HDL. The organs with the greatest concentrations of cholesterol are the adipose tissue, brain, liver, muscle, intestine, skin. And while the liver is the main regulatory organ for cholesterol, it may contribute only about 10% of cholesterol synthesis. The rest of these other parts of our body make cholesterol on their own. So what else do we know? Well, the brain makes all of its own cholesterol. It's an independent corporation. It's kind of neat to think about that. The brain is such an important organ. We wouldn't want it to be short of fuel, and cholesterol represents fuel in many cases for a lot of important organ functions. And so the brain makes all of its own cholesterol. In fact, LDL cholesterol doesn't even get into the brain from the bloodstream. It doesn't cross what we call the blood-brain barrier. Depending on the health of a mother, at birth, LDL cholesterol can be very low, between 20 and 65 milligrams per deciliter. I always remind people of that because one of the things people often ask me about is, hey, Dr. Underberg, is my cholesterol too low? Should I worry? And at the time we're born, when all of the important things in our body are developing, including our neurologic system and brain cells, our cholesterol is as low as it's ever going to be. And so again, low cholesterol, probably not much of a concern. I'll speak to that in a little bit. More than half of the cholesterol in your bloodstream is not inside cholesterol-containing particles such as LDL and HDL. It's actually on the surface of red blood cells. So when your cholesterol levels are low, you still have plenty of cholesterol. No need to worry about this at all. So people often talk about, or use a phrase, the LDL hypothesis. Hypothesis that LDL causes atherosclerosis, cardiovascular disease, heart disease. We in the cholesterol field do not use the term LDL hypothesis because it's not a hypothesis. It's been proven that LDL is causal in atherosclerosis. And that's based on animal experiments where you can raise cholesterol in animals and show that they develop atherosclerosis, and you can lower cholesterol in animals and show that the cholesterol, the atherosclerosis melts away, goes away. There's a lot of great, what we call observational or epidemiologic study data showing that if you look at populations of patients and you measure their cholesterol, their risk of heart disease, stroke, heart attack, vascular disease, etc., tracks with levels of cholesterol. As cholesterol levels go up for a group of patients over a period of time, their risk for cardiovascular disease and atherosclerosis goes up. And as their levels go down, that risk diminishes. More recently, we've got a lot of great, what we call randomized clinical trials. These are where we do interventions to lower cholesterol. We wouldn't do interventions to raise cholesterol. But these cholesterol-lowering trials have gone back since the early days of my training. And I'm not going to tell you when that was. But we've learned over a long period of time that if you lower cholesterol safely, you can reduce the risk of heart attack or stroke. Now, you probably have to lower cholesterol a certain amount. You probably have to lower it about 30% to really see benefit. So a 5–10% reduction in cholesterol probably isn't enough to see that benefit. But we do know that if you lower cholesterol safely through a variety of different cholesterol-lowering mechanisms, you can reduce the risk of heart attack and stroke. And then finally, I think the most compelling is genetic analyses. We look at patients who have genetic mutations that either raise or lower cholesterol over the course of their lifespan. And it turns out that if you have a gene that increases your cholesterol over time, you're at greater risk for heart attack and stroke. And the opposite, if you have a gene that lowers cholesterol, you seem to be protected, heart attack and stroke and atherosclerosis. So LDL is causal. And I'm going to try not to show you too many charts and graphs like this. I know it's a lay audience, but I think this is very important. This shows different types of clinical data. And in the red, these are the randomized clinical trials where we give people drugs. They're the shortest. They're 3 to 5 years. And the curve is the least steep. The medium curve in the middle in blue is the observational studies, where we follow people between 10 to 30 years to see what the effect of having high or low cholesterol is on heart disease risk. And the curve that is the steepest, showing the greatest effect, is the genetic data, meaning that the longer you are exposed to over the entire course of your lifespan, if you have mutation, it begins from the day you're born. So the longer you are exposed to a risk factor, such as high cholesterol, or longer that it is removed, if you have low cholesterol for a longer period of time, you benefit the greatest. Well, why is this important? Because it speaks to the importance of early intervention. If we know that patients who have low cholesterol from birth do the best, common sense would tell us then that impacting cholesterol earlier on in life makes a lot more sense than later on in life. It's kind of like you buy a new car and the front end is out of alignment. You can wait until you've been driving it for 5 years and need a whole front engine replacement. But if you go to the auto shop and have them balance your tires, you never have to have a problem. And so I think it's very important to think about this data in the context of why we want to intervene sooner and understand risk as soon as possible. So how is cholesterol trafficked in the body? I'm going to give you some information. When I'm done, you're going to know more about cholesterol than most physicians do. So cholesterol does not float in the blood like logs in a river. It can't. And the reason it can't is because cholesterol and triglycerides are fats, they're oils. And the blood is essentially water. And we know that oil and water don't mix. So cholesterol is trafficked throughout the body inside water-loving vehicles or particles. These particles have names that you already know: LDL, VLDL, HDL. Think of them as vehicles on a road. You have different kinds of vehicles. You have cars, you have trucks, you have vans. The passengers inside the vehicles are the cholesterol and the triglycerides, and they're being trafficked inside these water-loving vehicles. And they're called lipoproteins. And this is what a lipoprotein looks like. The lipoprotein has cholesterol and triglycerides in the center, and then it's surrounded by a coating of water-loving molecules that protect the cholesterol and the triglycerides from the water that they're actually being trafficked in. And it's these lipoprotein particles that bang into the artery wall and force their way in. So if we want to understand what's going on with cholesterol and risk for heart disease, we don't really want to know how many passengers there are. We want to know how many vehicles there are. And that's why looking at ways of measuring these vehicles becomes a far more sophisticated way of understanding someone's cardiovascular risk when it comes to cholesterol. And so rather than just measuring things like cholesterol, LDL, HDL, we often measure things like ApoB. ApoB is a measure of the number of particles, and it's a far more accurate way of thinking about how someone's cholesterol is interacting with their artery wall. So where does cholesterol come from? Well, about 20% comes from the food you eat. Why is that important? Well, many people want to lower their cholesterol by reducing the amount of cholesterol in your diet. Well, if only 20% of the cholesterol in your body is coming from diet, and you reduce your cholesterol intake by half, by 50%, you've only lowered the amount of cholesterol in your body by maybe 5 to 10% as best. And guess what? If you reduce your cholesterol intake, the body is smart. It just starts to absorb more of what you're giving it. And so typically, dietary manipulations of cholesterol don't change cholesterol that much. Now, I put a word of caution on this. There are some people who happen to absorb more cholesterol than others. And for those patients, dietary manipulation of cholesterol matters more. And in fact, one group that it really matters a lot in are patients with inherited high cholesterol, because they tend to absorb a lot of cholesterol. So they respond well to diets that are restricted in cholesterol and saturated fat. But most of the cholesterol is made by organs in the body, including the liver. And so 20% of your cholesterol comes from food you eat, 80% is made in the body, including in the liver. And so when we measure cholesterol, it's a mix of both. One of the things that comes up often is how safe is very low cholesterol. We've got all these great ways of lowering cholesterol now. So I always want to make sure when someone asks me about it, I first talk about the benefits. So what are the benefits? Well, it seems to reduce the amount of plaque that people have in their arteries. It reduces the risk of cardiovascular death, heart attack, stroke, need for procedures to fix blockages called coronary revascularization, and reduces the risk of something called unstable angina, which is new onset of chest pain or reduced blood flow to the heart. Statins and low LDL cholesterol in general do have some side effects. There may be an association with worsening blood sugar. I don't think this is clinically relevant. It's trivial, and I tell people about it because I think they need to know about it, but I do not think it's a reason to not take cholesterol-lowering medicines. Some people ask about bleeding and whether there's bleeding risk, especially in the brain with low cholesterol. And again, the data seems to not really support this. However, in the setting of acute stroke that was related to bleeding, I probably would wait until someone was stabilized before I gave them cholesterol-lowering medications. Low cholesterol does not cause cataracts, and there's no data to support any association with cancer risk, any liver toxicity, any causes of dementia, issues around low testosterone levels, or blood in the urine. So I make it clear, low cholesterol is pretty safe. Now, high cholesterol can be caused by lifestyle, can be contributed by diet, but genetics plays a big role. And I always say that cholesterol can be a family affair. I remember that TV show from growing up, so I put it here for you. But there's a condition called familial hypercholesterolemia. I spend a lot of my time seeing patients with this condition. It's more common than people think, and it's often mistakenly referred to as a rare disorder, and it's not. Patients with familial hypercholesterolemia have high cholesterol from birth. They have a family history of high cholesterol or early heart disease. Typically, heart attacks or strokes in men before the age of 55 and women before the age of 65. And typically, their LDL cholesterol, untreated, is greater than 190 milligrams per deciliter in adults and 160 milligrams per deciliter in children. And we call it FH. I've listed two resources here, not just for FH, but for cholesterol issues and lipoprotein A, which I'm going to talk about in a little bit. One of them is called the Family Heart Foundation, and you can find them at familyheart.org. And the other is the Foundation of the National Lipid Association. Full disclosure, I'm the current president of this foundation, and you can find us at learnyourlipids.com. That's learnyourlipids.com. Both of these are not-for-profit organizations that promote awareness, information, advocacy, and screening around all types of lipid or cholesterol disorders, not just familial hypercholesterolemia. But familial hypercholesterolemia, as I mentioned, is not uncommon. It's seen in approximately 1 in 250 people worldwide. But in the tri-state metropolitan area, New York, New Jersey, Connecticut, it's probably closer to 1 in 110. And the reason for that is there are certain groups of patients that are at greater risk of having familial hypercholesterolemia, and we tend to see those patients living in this area. Patients with familial hypercholesterolemia have a greater than 20 times risk of heart disease over the course of their lifetime. These patients tend to be underdiagnosed. More than 80% don't know they have high cholesterol, and we actually published a study many years ago. Our fellow at our Heart Disease Prevention Center published some data showing that only about 1% of patients who have this condition are actually told by their practitioners that they have it. So if you have familial hypercholesterolemia, certainly ask your provider about cholesterol-lowering medications, take medicines, and it's also important to screen first-degree family members. I can't emphasize this enough. When I see a patient who has this condition, I always talk to them about their siblings, their parents, and their kids. They all need to be screened for high cholesterol. I showed you that artwork early on, and patients who have familial hypercholesterolemia can have findings around the eye. We call this xanthelasma, or they can have something called a corneal arcus at an early age, which is a white ring between the sclera and the iris. They can have these nodular densities in the Achilles or on the extensor surfaces of the hands. These are called xanthoma. And so there are physical findings. Now, we have many medications that are now available to us to lower cholesterol. And I mentioned that in my introduction, how lucky I am to be able to access all of these options. Statins remain the cornerstone, and many of you may be on statins. They have names like atorvastatin, rosuvastatin, simvastatin. They used to be called Crestor, Lipitor, Zocor, et cetera. They're all generic now, which is great. They're less expensive, easier to obtain. And they lower cholesterol about 30 to 50%, and they've been shown to reduce the risk of heart attack and stroke. In addition, we have another drug often forgotten, but also around for a while, called ezetimibe. Used to be called Zetia. Lowers cholesterol around 15 to 20%. Works through a different mechanism than statins. It works on blocking the absorption of cholesterol in the intestine, but it does not have any stomach-related side effects. Statins work by blocking the production of cholesterol, and they almost trick your body into removing cholesterol from the bloodstream into the liver. Zetia is not as potent, or ezetimibe not as potent as statins. It lowers cholesterol 15 to 20%. And there is data showing, just like statins, that it reduces the risk of heart attack and strokes. We have newer agents that are injectable called PCSK9 inhibitors. These are more potent even than statins, between 50 and 60%. They're injectable, given every 2 to 4 weeks. And the newest agent, inclisiran, I've listed on the bottom, can be given only twice a year by injection. There is data with both of the PCSK9 inhibitors that we call monoclonal antibodies. Their branded names are Repatha and Praluent, evolocumab and alirocumab. And we have data that they reduce the risk of heart attack and stroke when added to statins. Inclisiran, which is a different technology to lower PCSK9 levels, I said lowers cholesterol more, but we don't have data yet that it reduces heart attack and stroke risk. There is a clinical trial ongoing, and I suspect it will. There's no reason to think it won't. And the safety data seems to be similar. And again, you only have to inject it twice a year. Very recently, we had new data from a brand new agent. It's been around for about 2 years now, called bempedoic acid. Bempedoic acid reduces cholesterol between 17 and 25%. And it's been shown then combined with other cholesterol-lowering agents, but in patients who can't take statins, statin intolerance, to reduce the risk of heart attack and stroke. This is relatively new information. It's a great trial done in people who couldn't take statins, and for the first time, a clinical trial, more women than men. So very exciting to see this data. And so you can see we have a lot of different things available to us. And just some fun facts about statins. Statins reduce the risk of heart attack, stroke, and death from heart attack and stroke. The benefit is greatest in those with the greatest risk for cardiovascular disease. And that's always important when we think about using these agents. Greatest benefit is in those with the greatest risk. But people will often say, well, I'm young and healthy. And age is a risk factor. So if I'm young, I don't have high risk. But that's not always true, because if you're young and you have very high cholesterol, and you multiply the exposure of that cholesterol over the course of your lifetime, it automatically makes you high risk. Okay, so it's important to remember not just is what is my cholesterol today, but for how long have I been exposed to high cholesterol? So what else can we say about statins? They don't cause liver disease. They don't cause dementia. They prevent vascular disease from progressing throughout the body, including the brain. And vascular dementia is the most common cause of age-related memory loss. Statins do not cause diabetes. They slightly increase blood sugar. Statins do cause muscle aches. We call that myalgia. About 9% is a good number to hang your hat on. And the risk is greatest based on age, increasing age, female sex, and people who are on other drugs. Sometimes there can be drug interactions that make statins more potent, so to speak. And again, the earlier you treat, the better. So in the last part of this talk, I want to talk about lipoprotein A. Lipoprotein A is an under-recognized risk factor for heart disease. There's been a lot more awareness about lipoprotein A recently, and I think part of that is because it's a very exciting time. We've got several new drugs in development that specifically target lipoprotein A. So what is lipoprotein A? Lipoprotein A is essentially LDL cholesterol with an extra little piece attached to it. The way I explain it to my patients is think of it as LDL cholesterol with Velcro attached to it. So LPA, lipoprotein A, which is LDL that is stickier, is more likely to get into your artery wall and stay and do damage to the underlying vasculature. And so when we measure lipoprotein A, we're really measuring LDL with this extra little protein attached to it called ApoA. And the entire entity is called lipoprotein A. And this is what lipoprotein A looks like. Over here on the right, the spherical structure is LDL. And wrapped around LDL is a very important protein called ApoB that gives us its identification. And then attached to the ApoB, via a little bond here called the disulfide bond, is this repeating unit of what we call kringles that forms the ApoA molecule that gives the entire structure its name, lipoprotein A. And why do we call these repeating units kringles? Because they look like a Danish pastry called a kringle. And so why does this increase the risk of heart attack and stroke? Well, I like to think of lipoprotein A as a fishing trawler and a net. If the fishing trawler is LDL, think of the net as the ApoA part of lipoprotein A. And the fishing trawler goes through the ocean over the course of the day, and it's running its net underneath the boat. And at the end of the day, the contents of the net is dumped on the deck of the fishing trawler. And there may be fish in the fishing trawler, but there's also a whole collection of flotsam and jetsam that needs to be discarded. And that flotsam and jetsam that's being collected over the course of the day is exactly what lipoprotein A is collecting as it moves through the bloodstream. It's collecting things called oxidized phospholipids. And these oxidized phospholipids are highly toxic to the artery wall and also to the surface of heart valves, such as the aortic valve. And patients with elevated lipoprotein A have an increased risk of aortic stenosis, along with an increased risk of heart attack and stroke. The prevalence of this is very high. 20% of the population has elevated lipoprotein A. So that would be 73 million in the United States alone, and you can see it's distributed throughout the world. Lipoprotein A goes up based on race, sex, and risk for heart attack and stroke. Black patients tend to have higher lipoprotein A's than white patients. South Asians, Chinese have the lowest. Women have higher lipoprotein A levels than men, and you're more likely to have atherosclerotic cardiovascular disease if your lipoprotein A level is elevated. And data from observational studies and data from genetic studies shows this what we call linear relationship between levels of lipoprotein A and risk for atherosclerosis. And it seems to be a continuous relationship, although there are certain cut points that we typically think of. If you measure it in nanomoles per liter, the magic number is 75 is elevated. If you measure it in milligrams per deciliter, 30 is elevated. So it's always important to ask for this. I think everyone should have it checked when they're an adult at least once. The US recommendations are to check it if you have risk factors for heart attack or stroke, family history, or if you have heart disease or high cholesterol. In Europe, they suggest every adult measure it at least once. I think here in the US, we're getting to a point where everyone will get it checked once. We're not there yet, but the recommendations are actually being updated right now. I mentioned that elevated lipoprotein A can also lead to valvular disorders in the heart, specifically something called aortic stenosis. So if you have aortic stenosis, you should get your lipoprotein A level checked. And if your lipoprotein A level is elevated, you should certainly be screened for aortic stenosis. So what can we do now? Why do we want to know about this? Well, there are no drugs that are specifically approved, either to lower lipoprotein A or to reduce the risk associated with elevated lipoprotein A. But I think it's important to assess it at least once per lifetime, especially in high-risk patients. Why? Well, because it's a risk factor. It's just as important as knowing whether or not there's a family history of early heart disease. It's just as important to know whether or not you're a smoker, or whether or not you exercise, or you eat a heart-healthy diet. So it helps contextualize your risk going forward for heart disease. If it's elevated, it also means that family members should be screened, first-degree family members. I always say north, south, east, and west. So parents, children, and siblings. We also know that if your lipoprotein A level is elevated, lowering the LDL seems to minimize the risk from the elevated lipoprotein A. There's also some newer data that low-dose aspirin, especially in higher risk patients, may benefit patients who have elevated lipoprotein A. I'm not by any means suggesting that everyone with lipoprotein A elevations be on low-dose aspirin. I'm just letting you know that there's some data out there suggesting that in some patients, the use of aspirin may be beneficial, and there may be other ways to better find out who those people are. But what's really exciting is that we've got a host of agents in the future that are in development right now that seem to do a great job at targeting lipoprotein A. We've got some drugs that we call antisense oligonucleotides. They seem to break down the coding RNA that creates the lipoprotein A, the ApoA protein. There are drugs that interfere with the messenger RNA, and I've listed two here for you that are in development. This is very exciting right now, and we're doing some of these trials at NYU. My colleague Howard Weintraub in our Heart Disease Prevention Center leads this effort, and it's great because we can refer patients to our center who have these issues and get them enrolled in trials that offer some of the newest agents. There are agents right now that do reduce lipoprotein A. The PCSK9 inhibitors that I mentioned earlier for LDL lowering lower lipoprotein A about 25 to 30%. The issue here is that when you look at genetic data, it seems that you need to lower lipoprotein A about 80% to make a difference. Now, the drugs that are in development that specifically target lipoprotein A do lower lipoprotein A anywhere between 80 to 95%. PCSK9 inhibitors only lower lipoprotein A 25 to 30%. So while it works, whether or not it's actually doing anything beneficial, I think still remains to be seen. Niacin is another drug that lowers lipoprotein A, but we don't use it to lower lipoprotein A because it's got a lot of other side effects and hasn't really been shown when combined with other cholesterol-lowering medications to reduce the risk of heart attack and stroke. People often ask me about estrogen. Estrogen will lower lipoprotein A, but I would never put a woman on estrogen to lower lipoprotein A. And statins actually can raise lipoprotein A a little bit, but that doesn't seem to have a negative effect. And so do not be alarmed if you're on a statin and your lipoprotein A goes up. So if we think of the evolution of lipid-lowering therapies from statins to ezetimibe to the monoclonal antibodies against PCSK9 inhibitors, and now the biannually injection of inclisiran, we've come a long way. We've got newer drugs in development that target lipoprotein A, and I've listed some of them. We've got some folks working on vaccinations, but I think the real excitement in the future going forward is actually something called gene editing or CRISPR-Cas9, and I'm sure you've heard about this in the news. There is one company up in Boston called Verve Therapeutics that's working on a one-time intervention to turn off the gene either for PCSK9 or something else called ANGPTL3. And if you do this, you lower cholesterol at any time. Once you make the intervention, it's a single intervention. The only potential negative here is that it's not reversible. So once you make the intervention, it can't be undone. But there are clinical trials going on right now in humans with gene editing with CRISPR-Cas9 to see if we can not only lower LDL cholesterol permanently, but whether or not this has a beneficial effect on future risk of heart attack and stroke. And I envision a time one day maybe where in those who have cholesterol levels above a certain number, you might be eligible for this intervention when you're young and never have to worry about medications or potentially future risk of heart attack and stroke going forward. So take-home points here, statins and ezetimibe are really first and second line options for lowering cholesterol. They're oral, they're generic, and I think they're relatively safe, although there always are side effects that you have to be aware of. It's important to get your cholesterol checked. Understand it in the context of other risk factors for heart disease, because remember, it's your risk that determines benefit from cholesterol lowering. Check lipoprotein A. I think if you're going to get your cholesterol checked, in my mind, that qualifies you at least once to have your lipoprotein A checked. It's inherited. If it's high, you got it from your mother, your father, or both. And if it's high, you need to screen any kids or siblings as well. New lipid-lowering therapeutics are alive and well. PCSK9 inhibitors now include two different modalities, monoclonal antibodies and what we call small inhibitors of RNA. Praluent and Repatha are the monoclonal antibodies, and inclisiran is the small inhibitor of RNA. Bempedoic acid, called Nexletol, offers another approved oral lipid-lowering option, especially in patients who are statin intolerant. And there are outcome trials going on with inclisiran. And finally, new therapeutics in development targeting lipoprotein A are in progress, and gene manipulation is closer than you think. So finally, I always like to finish in the words of Ferris Bueller.
Life moves pretty fast. You don't stop and look around once in a while, you could miss it.
So I thank you very much. This is Bellevue Hospital where I trained. I have a collection of old postcards from Bellevue, and I have very fond memories of my time there and enjoy my time there now. It's a wonderful institution, and we're lucky we have it here in New York, as well as NYU and our Heart Disease Prevention Center. So I'll end on time with 15 minutes left for Q&A. Not bad, Dr. Goodman, and I'll send it back to you.
You know what? That was outstanding. You're an absolute pro. You did an absolutely amazing job, and I think you simplified the topic so well and gave so much amazing information. I've got several questions. We put some of them up on the screen because it just makes it easier, and you can try to answer them sort of short and briefly so we can get to as many as possible. But we're going to start off with, what is the optimal range for cholesterol?
Sure. And again, you have to contextualize optimal levels also within the particular patient and risk for heart disease. So in someone who is otherwise healthy, I would say an LDL cholesterol less than 100 in my mind would be optimal. In someone who had heart disease, I would want the LDL to now be less than 55. And so those are just two quick numbers to hang your hats on.
Thank you very much. And that is one of the reasons that we are so aggressive in bringing the LDL down in people who have heart disease or they've had a stroke, because we know the data is so clear that if the lower the cholesterol, the LDL cholesterol, the better. And luckily, as you've mentioned, we've got really amazing medications that can really lower the LDL very significantly. Next question, why do I get yellow spots under my eyes and my cholesterol is low?
Oh, that's a great question. So I showed you that patients with very high inherited cholesterol, familial hypercholesterolemia, can get deposition of not cholesterol, but kind of reactive, what we call reactive giant cells in the intranasal folds around their eye. And it's called xanthelasma, and it's a yellow waxy appearance, but it's not cholesterol. But it turns out that the most common cause of this is no cause at all, and it doesn't come from high cholesterol. And unfortunately, these behave often like keloids, and sometimes when people try to have them removed surgically, they can actually come back with a vengeance. So I always caution patients who are referred to me with these findings that if it's not because of high cholesterol, which is usually the case, be very careful about what you do to try to remove them. Cholesterol-lowering medicines won't have an effect. They can be removed surgically, but it has to be done by someone who really understands what they're doing.
Great. Is it possible to have a normal cholesterol and still have blockages or still have a heart attack?
And the answer is, of course. You can have normal cholesterol, but you could have high lipoprotein A. That's one of the first things that you and I always check for, Dr. Goodman, is when someone comes to me and their cholesterol is normal and they've had an event, I want to make sure we check their lipoprotein A. But there are lots of other things that can cause vascular disease that don't relate to cholesterol. And so it's just part of the puzzle. I showed you that Life Simple 8. Cholesterol is just one of 8 in that question there.
I remember a patient I had who was very strong, fit, 39-year-old male. He was on the basketball court. He had a heart attack. He came in. I had to put a stent in, and he did well. But his lipids looked great. It was to this point, to this question. I checked his LPA, and it was very high. So it's just to your question, to your point, that the LPA alone can be a significant factor, and that's why it's so important to check it. how can a heart scan, that's a coronary calcium scan, show a high score while other tests aren't showing blockages? I'll just weigh in quickly and say we do use, I don't know about you, Dr. Underberg, but I know I use a lot of calcium scoring, and you also do it. It's just a non-invasive way of looking to see if there's plaque in the arteries. And we call it's called hard plaque because it's calcium. And there can be a high score. The calcium score could be over 400, and you may not have a significant blockage. You have atherosclerosis, but you don't have a blockage that's 70% or more. And so what we often do with patients who have a high score is to do some kind of stress testing to see whether or not there is ischemia related to a blockage. Turns out that when a score is over 400, there's about a 25 to 30% risk of having a blockage. And many a patient who's actually been asymptomatic has had calcium scans and land up having stents and bypass surgery, especially in the old days before we had trials that show you can be more conservative with treatment. So I'd like you to add to that and just tell us how often you use the calcium score.
The calcium score is a great tool. Originally, it was recommended as an additional risk assessment tool that we could use to help determine whether or not we felt the patient needed to be on cholesterol-lowering medication, almost like a tiebreaker if you weren't sure. I would tell you that our thinking, I think you would agree with me, has evolved. And I have patients that are on cholesterol-lowering medication, and now I sometimes use a calcium score to help me determine if I'm doing a good enough job. Do I need to be even more aggressive? When we didn't have a lot of tools, there wasn't a lot we can do. But now, because we have the ability to make cholesterol low, I don't want to miss an opportunity in someone who needs to have low cholesterol. And so it's just another way of unearthing risk and getting kind of to the core of what's going on, so to speak.
I had a question from Laura, which this is applicable to, I think, who's, let's say she's 60 years old, and she has a high LDL cholesterol over about 165, but with a high HDL as well. No other risk factors. And let's just say that she has a family history of heart disease. And she wants to know, should her LDL be treated? And I think this is a perfect example of a situation where the calcium score can be very helpful.
It can be. And I would also remind people that,
and the LPA.
that high HDL cholesterol, which is often mistakenly, I think, referred to as the good cholesterol, does not protect you against elevated levels of LDL cholesterol. And in fact, when HDL levels become very high, the HDL becomes dysfunctional. It doesn't work right, and it can actually be what we call pro-atherogenic, or promote atherosclerosis and heart disease. And finally, there is a syndrome that's been identified in patients with very high HDL that seems to be associated with high lipoprotein A levels. So when I see a patient with high HDL, I want to immediately know what their lipoprotein A is. HDL is made primarily in the intestine. And when someone has high HDL, it's also a clue that they might be a high absorber of cholesterol. And this often happens after the menopause in women. They start to absorb more cholesterol and HDL levels can go up. And it's not a protective event because we know the risk of heart disease shoots past men after menopause. So HDL can tell you a lot about what's going on in someone.
To your point, many years ago, as you know, Pfizer had a drug called torcetrapib, which was a CETP inhibitor, and the HDL cholesterol was going up 70 or 80%. And it turned out the study showed that people on this drug were doing worse. And what we figured out is that maybe it's partly because of a slight increase in blood pressure, but it also turned out that we think the HDL was dysfunctional. So to your point, how do we know if someone's got a high HDL, whether or not they have a dysfunctional HDL? Because in some patients, it is protective, isn't it?
Yes, in some, I think it represents things that are protective, right? HDL goes up with certain diets that are heart healthy. HDL goes up with exercise. HDL goes up if you stop smoking. But we don't yet have an assay that measures HDL's ability to do good things, so to speak. So I think it's important to look at some of the other surrogates, such as a coronary calcium scan, as you mentioned.
Okay. And also, I think an LPA would be very important there too, because if the LPA is elevated, we would certainly treat that lady, Laura. What test can I get to diagnose familial hyperlipidemia?
So it starts with the LDL cholesterol. Typically untreated, we use the number greater than 190, which is the 95th percentile. But we've now got the ability to do genetic testing, specifically targeting the most common genes that mutations have been found in that are associated with the condition familial hypercholesterolemia. And I tell my patients that genetic testing is kind of like cell phones. They were once very expensive and didn't do much. Now they've become relatively inexpensive and in fact free in many cases and do everything. And that's the case with genetic testing. The cost of this has come down significantly. And it is a part of the diagnosis of familial hypercholesterolemia, but there are some people who have familial hypercholesterolemia, but we don't identify a mutation. And it doesn't mean that you still don't have to treat the condition.
One of our audience made the point that a lot of doctors don't check LPA, and maybe the incidence is even higher than what you mentioned. And I think that's a good point.
Yeah, we get the numbers, the incident numbers from large databases. And so it's independent of whether someone's screened or not. Still, I think that at least here in the United States, the information I hear often from patients when we find out that their LPA is elevated and I tell them to get their family members screened is they'll say, oh, my brother's doctor didn't want to check it because they told him there's nothing to do about it. And my answer is, well, there's nothing to do about a family member who died from a heart attack, but you'd sure want to know about it. And so again, I think information is a good thing, even if we don't have a drug yet approved to treat it.
Right. And as you said, the future is looking rosy in terms of finding drugs that will be able to lower it significantly. Do statins prevent heart attacks? You've answered that beautifully, absolutely, in people who have high cholesterol. Is cholesterol really the problem? And I think I'm going to change that to, is cholesterol the only problem? Because we know that LDL cholesterol clearly is a major factor, and that's why statins work. But what about other things that we should be focusing on? And clearly this is where it's so important to think about lifestyle changes, the exercise, the eating healthy, stress management, sleeping well, and as I said, socialization and connectivity. What's the best way to reduce LPA? I think you've discussed that. It's not possible to reduce LPA without taking some form of medication. One of our audience said to me that they were on a statin and ezetimibe, and the LPA went up by 7 points. I don't think that's clinically significant. What do you feel is is there any evidence that the LPA can go up with medication? And would you worry if it went up slightly?
So the answer is yes, it does. We know that statins slightly increase LPA, and that doesn't seem to impact the benefit on cardiovascular risk reduction. And it would not be a reason for me to stop someone's statin, because LPA creates a patient in a higher risk category. And we know the higher the risk, the greater the benefit from the statin, given the same amount of cholesterol lowering. One of the things that LPA does, though, it creates the blunted effect for cholesterol lowering. So if you don't respond to a statin the way your provider thinks you should, then make sure you get your lipoprotein A checked, because if the lipoprotein A is high, it could account for a blunted effect on LDL lowering. I do want to point out one thing before we're done, which is that we haven't mentioned that for patients with elevated lipoprotein A who have heart disease and continue to have events or problems, there is one accepted treatment. It's rather invasive. It's called apheresis, where we literally remove the lipoprotein A from the bloodstream, much like dialysis, and then give the blood back without the lipoprotein A. And so there is something that we can do right now today, if needed in the worst cases.
You covered the next two questions. Let's go to the next one. What are the negative side effects of taking statins? You did mention you can get muscle aches. Somebody want to know, why do you get muscle aches? And why do we get, sometimes joint pains and muscle aches? And I know that CoQ10, I know that, the lowering of CoQ10 has been touted as one of the things that can do that. And the studies haven't really borne out that it can make a difference. But I do want to say in my own practice, I have put people on CoQ10 at times, and it has made a difference. I don't know if you ever use it or whether you're a purist, and you tell us how you would handle muscle aches just briefly.
Yeah, I generally try to find a drug that doesn't cause a problem. Sometimes if people have tried multiple statins, um, they consider it, but it's not an inexpensive supplement. And the data surrounding its use isn't that robust. So I don't promote it. You know, we used to think that low vitamin D might increase the risk of statin-related myalgias. Newer data doesn't seem to support that either, unless perhaps it's extremely low, below 15. Thyroid disease, intercurrent thyroid disease, can increase the risk of statin-related muscle complaints. And so there are some things we can do. And sometimes just changing to a different statin or alternative dosing seems to help. But we try everything we can to get people to take these medicines since they work so well.
I just wanted to quickly just mention that I had some questions about eggs. So one of those controversial areas, I wanted to just refer people to an article that was written in a journal called Nutrients. And you can look it up on Google, Eggs, Healthy or Risky, by Madeleine Maz. And she does a great job of talking about eggs. And the fact is that eggs are very healthy. They've got a lot of choline, folate, vitamin D, iodine, and high quality protein. And most of the time, the eggs are not a major problem. And you can have between 2 and 4 eggs a week, as long as your cholesterol is not going up because of the eggs. And that is something that's very easy to check. I also wanted to say, Dr. Underberg, that as you know, I'm integrative, and I have had some patients who don't tolerate statins very well. And I've managed in patients who don't have significant heart disease at that time to use a drug called bergamot, which is from the lemon of a citrus lemon that's grown in Italy. And I've seen reductions of 30 to 40% in the cholesterol. So there are some alternatives, but it's very important that you do it in conjunction with your physician. If you have significant underlying plaque, or you had heart attacks or strokes or already cardiovascular events, I believe it's absolutely essential to be on a statin or one of the other medications. Dr. Underberg, that was outstanding. I wanted to just, if you could just put the number up, Anya, for patients that would like to come and see somebody on our team. NYU Langone Center for the Prevention of Cardiology Disease. You can make an appointment at 212-263-4300. We have a team of excellent preventative cardiologists, and you will get all the information you need about prevention of cardiovascular disease. Our website to register, as I said, is nyulangone.org/heart health lectures. And if you've got any questions or you've got any suggestions, please email us at hearthealth@nyulangone.org. I got a few comments to say how much the audience has enjoyed your presentation today, Jamie. So thank you so much. It was really outstanding. I really appreciate it. And thank you, Anya, as usual.
So long. Thanks so much, everyone.
That was great, Jamie. Thank you.
All right.